Hello and good morning. My name is Luis Guirado and I'm a nephrologist working in Barcelona at the Fundació Puigverd Hospital. The purpose of my talk is explain the kidney exchange program between three countries, Spain, Portugal, and Italy. As you know, Spain has been first country in the world in terms of obtaining organs from deceased donors. 2 years ago, we obtained 49 organ donors per million population. This is a too high rate. And looking what has happened with the Spanish waiting list is the red line. We have been able to decrease our waiting list. And at the same time, we have increased the number of renal transplants. And it seems that every year we can transplant all the recipients we have. But this is not true. If we look at what happens in the country during the whole year, the number of patients that we introduce in the waiting list and the number of patients we can transplant, we can only transplant 50% of the patients that have passed across the waiting list during one single year. And that means an average of 2 years in the disease organ waiting list. This was the reason to try to increase our living organ donor program. And you can see here in this slide how we can do it. But one of the programs we introduced in the country was the crossover transplant. And 8 years after the starting in 2009, we noticed that we only could transplant 30% of the patients in this crossover transplantation program in a single country, Spain. Why? Because we needed to add more pairs at the program to increase the possibilities of finding a match between pairs. That was also the reason to look at Europe, because we had created in 2012 the South Alliance for Transplant between different countries. And one of the purposes of this South Alliance organ transplant was to create an international cross-border organ exchange program. And what country can we choose to exchange? At this moment, we decided to work with Italy and Portugal because they were very close to Spain. And we had a close relationship between the three organization programs for transplant. And we have also in Europe other countries that work with exchange programs, and also many countries that have not created these exchange programs. And we signed an agreement between the three countries, Italy, Portugal, and Spain. And with this agreement, we try to work together to create a supranational registry to include a high number of participating hospitals, to work with a virtual cross-match algorithm, and also to define some operating rules. To participate as a hospital, they needed to have more than 10 living donor kidney transplants per year, and also to participate in the corresponding national crossover program. As a qualitative, the nephrectomy has to be performed by minimally invasive techniques, to accept the supranational crossover donation protocol, to have an HLA accredited lab, and at the same time to have a responsible person in each country and in each hospital. The virtual cross-match algorithm takes into account blood types, the matching probability, the age difference between donor and recipient, the time on dialysis, and also if the transplantation was pediatric or not. Also, there are some ethical issues to have a specific informed written consent, anonymity between countries and between pairs. And we need an ethical consent from, an informed consent from the ethical committee, also go to the court to have the acceptance of the judge. The nephrectomies have to be simultaneous, just at the same time, to have direct contact between surgeons to start at the same time. The nephrectomy is at the place of the donor, and we ship the kidneys country to country. The logistics are managed by the national transplant organization teams, and the language between us has been English. The time from the beginning and the end, the day of the transplant, takes about 2 months. And the first one of this transplant was done just some months after signing this agreement. The first one was between Italy, Padova, and Spain, Barcelona. And this is the slide showing the moment at the Barcelona airport in July 2018, when we received this blue box. This is the kidney from Italy, and we send the kidney from Barcelona in the same plane. Of course, we need much more countries to increase the probabilities of finding pairs with a good match. And of course, all the countries that want to be admitted will be admitted in this alliance. And I would like to finish giving my thanks to the 3 organizations, the Spanish Organization for Transplants, the Italian one, and also the Portuguese one, and of course, to all the people who have participated in this program. Thank you very much for your attention.
In the name of God, I'm Dr. Alireza Oliaimanesh, professor at TAMS, Tehran University of Medical Sciences. This is my honor to have a presentation in 44th World Hospital Congress as the Congress of International Hospital Federation in Barcelona. In this short presentation, I'm going to present the result of one national study on the prioritization of the sources of inefficiency in the health system of Iran. First of all, I would like to introduce my colleagues in this study, which were Dr. Effat Mohammadi, Dr. Farhad Habibi, Dr. Mohammad Reza Mobinizadeh, and Professor Amir Hossein Takian. As you know, the importance of efficiency has been stated in Iran's national development plans, and also in a recent health transformation plan of Iran. An assessment showed that there are huge inefficiency in the health system of Iran. So we started and conducted a study with the aim of assessing the main sources of inefficiency in the health system of Iran. So first of all, to tackle these sources of inefficiencies, we had to specify these inefficiency sources and then prioritize them to be able to tackle them. So we planned a three-phase study, and in the first phase of this study, we did a comprehensive review to identify the sources of inefficiency in the health system of Iran and other health systems around the world. And then the output of this phase of the study was a list of causes of inefficiency. In the second phase, we reviewed studies and conducted an expert panel. So with that, we had been able to prioritize these causes of inefficiencies. And then we tried with the expert panel to weight these inefficiency sources. And at the end, we had a list of weighted criteria. And in the third phase, we used MCDA method to rank these sources of inefficiencies. So among the 300, more than 300 sources of inefficiency, at the beginning we specified about 48 main causes, and then we reached to 7 most important sources of inefficiencies, which were inefficiency in hospital services, inefficiency in service provision, supply and demand, human resources mismanagement, lack of service classification, and lack of comprehensive referral system, inefficiency of insurance funds, in strategic purchasing of health services, inefficiency of payment and tariff method, and inefficiency of e-health in the country's health system. And here are the 48 main causes with the rank that have been done by the expert panels at the health system of Iran. So finally, we did a root cause analysis for these 7 main causes of inefficiencies, and we, based on that, we prepared the papers, which is published, and here I'm presenting the result of that paper. Thank you very much for your patience.
Good afternoon, everyone. I'm Shalomi Shadrack. I'm an epidemiologist at Darling Downs Health. Darling Downs Health is a hospital and health services in Queensland, Australia. I'm here to share with you the lessons we learned from evaluating BABES project. BABES project is a quality improvement project. BABES project looked into improving the antenatal care services provided for Indigenous Australians, and also looked into the services available in rural, regional, and remote Australian settings of Queensland. BABE stands for Bridging Antenatal Care, Indigenous Babies, and Smoking Cessation. The population targeted were pregnant women carrying Indigenous babies. The problem that we were trying to address were healthcare access inequalities. And the way we were trying to do that was through integration of antenatal care services through the universal healthcare model, as well as looking into motivational incentives to improve the services. Participation, actually. Outcome, we were trying to reduce the gap between the inequalities. Darling Downs Health services an area of 90,000 square kilometers and around 300,000 population, and of which about 5%, which is 15,000 people, are of Indigenous origin. And of them, the BABES targeted only those reproductive aged women from 20 to 50, which were around 3,000. And then some teens, which there were around 700 teens. However, we had looked into teen programs as well, because we had an issue with teen pregnancy. There were around 3,500 babies born every year in our region, which included 350 indigenous babies. In summary, our project aimed to reduce the inequalities between the service gaps. And how we tried to do it was having localized antenatal care service model, as well as we also looked into closing the gap indicators by Queensland Health, which included improving proportion of earlier and regular antenatal care for Indigenous women, as well as smoking cessation post 20 weeks of pregnancy. So the activities we undertook for that took into consideration infant mortality rate in our region as well. So a literature search revealed that Finland model was really good, so we adapted it and had our own model. We did a logic model in order to come in terms with different stakeholders and the long and the short and the medium, outcomes based on the expectation of each of those stakeholders. We looked into intervention programs. There were 3 different intervention programs we looked into, 2 of which was for the target 1 of the Closing the Gap initiative, which was earlier and regular. So the earlier one was the biggie bundle, and the regular or minimum of 5 antenatal visits included the Banya bundle. And then we had the smoking cessation project on its own. And then we also had integration of services, which included all the AMSs or Australian Medical Services, which are standalone health services on its own, and then the GP services. The good thing about all of this is all of these services send their mothers or the pregnant women to the hospital for birthing. Participation rate, we had a real good participation rate of, we covered around 76% of the birthing mothers, and that was around 236 for the biggie and the Banya bundle. However, there were only 73 of those who actually fell into the indicator with both of those thing together. And then the smoking cessation program also had an issue of recruiting people post 20 weeks of pregnancy, although the target was for us to make sure that they were smoke-free post 20 weeks. However, we continued doing that because by the time the baby was there, the home was smoke-free, even if we continued after 20 weeks. In general, we had about 10 Indigenous teenage moms, and then about 6 of them were smokers. So in general, this was a target put on for us. The target we reached was good for the target 1. We had about 60.9% of our birthing moms who had both Indigenous, earlier and regular antenatal visits. However, we failed so badly in our smoking targets. So in general, we use the universal health care concept by World Health Organization for the integration of the services. And it really helped in, nutting down the mutual benefited priorities of both the services. The challenges initially was to fund training, staff training, and have consistent flow of funding for sustainability of the project itself. The key things for our success were a supportive leadership team. We had a leadership team put in effort in cultural capability training, as well as recruiting Indigenous staff. The key lessons for you guys as policymakers from BABES would be to think about healthcare policies. When you're doing one, please promote integration of services and pooled funding approach in a region, especially if it is to do with the regional and remote areas. Key performance indicator, please consider population cohorts. One cohort is not same like the other one, as well as when you're doing a service targets on funding, please think of a holistic approach, which thinks about a patient-centered approach, not service-centered approach. Thanks for the opportunity.
The work I'm going to present is titled Territorial Management of Healthcare Quality and Patient Safety in the Field of Mental Health in Lleida. Quality and patient safety in healthcare has made significant progress over recent decades. However, work has predominantly been focused on physical health. This work aims to promote a model of excellence in mental health care. Catalonia is a region in the northeastern corner of Spain. Catalonia consists of 4 provinces: Barcelona, Lleida, Girona, and Tarragona. Gestió de Serveis Sanitaris is the main public company that provides mental health through a network of multiple healthcare centers in the Catalan province of Lleida. It has an area of influence of 400,000 people, and the territorial dispersion stands out, as it corresponds to less than 6% of the population of Catalonia, located in 35% of the territory. The aim of the work was to constitute a territorial quality and patient safety commission of mental health care and establish a quality and patient safety plan to improve the quality of care and patient safety to the care processes in the territory of Lleida. Findings. From June to December of 2018, constitution of the QMPS Commission in the field of mental health of GSS. The commission was made up of 17 professionals who belong to the field of care, the mental health directorate, and the quality area. Training in continuous improvement methodology, quality and patient safety to the members of the commission. Identifying key processes and the establishment of 5 working groups linked to each key process. Identification and priorization of improvement actions based on the contribution of professionals, the analysis of satisfaction surveys, the requirements of the health department of the Generalitat of Catalunya on accreditation and on patient safety indicators for acute hospitals, as well as the plan director of mental health and addictions of Catalonia and the health plan of Catalonia 2016-2020. 20 actions corresponding to strategic processes were approved. 6 to urgent care, 6 to outpatient care, 21 to hospitalization care, and 2 to medication management. It was followed up through quarterly meetings of the Commission. Some of the actions that we done include validated satisfaction surveys, a document of management system, unification of the documentation of assistive devices of outpatient care, a contact form in the website for patients and families, an adverse event reporting system, training in quality methodology to the members of the Commission, approval of a document conciliating the medication upon admission and discharge. In hospitalized patients, a reception protocol, a consent to provide information on a minor, an informed consent for voluntary admission, preparation of a coexistence document in the dual pathology unit, update of the mechanical containment protocol, suicide prevention protocol updated. In emergency area, an ambiguous identification system, training in cardiopulmonary resuscitation, in the hospital voluntary admission document. In December 2019, we closed the plan and 85% of the planned actions were achieved. We also discussed improvement proposals for the 2020 and 2021 plan, which are being carried out right now. Conclusions. Establishing a territorial commission and a QMPS coordinated plan has allowed developing strategies to integrate improvement actions in the care processes of mental health care area of Lleida. It has been used to promote a model of excellence based on the planning and assessment of enhancement actions adapting to the field of mental health, a model of quality and patient safety used in public acute hospitals in Catalonia. Thank you.
Thank you so much to the World Hospital Congress and IHF Barcelona for the opportunity to present today on the topic of designing and quantifying the effect of a value-based bundled care model for schizophrenia on patient outcomes and health service delivery and utilization. Acknowledgements to the team at Ontario Shore Centre for Mental Health Sciences for their involvement and achievements to date in this work. A bit about Ontario Shore's Centre for Mental Health Sciences. We are one of the 4 mental health specialty hospitals in Ontario, Canada. We're located in Whitby, Ontario, just outside of Toronto, on the shores of Lake Ontario. We're leaders in recovery, innovation, and client-centered care. And our HIMSS MRAM Stage 7 hospital, meaning we have a fully integrated medical record. A bit of background about this topic today, looking at bundled care models and really what this means. Similar to a quality-based procedure model, these have been successfully created and implemented in other more acute episodic areas of care, similar to hip or knee replacements. And what does this model mean? It means it's very much based in quality and an integrated pathway of providers, which creates a seamless experience for the patient, and it feels as though there's one team continuously serving them throughout their pathway. This has been challenging to date with the mental health diagnoses and particularly schizophrenia, given that the diagnosis really occurs and has treatment and supports and care needs over the course of one's lifetime, and there's varying levels of complexity and risk adjustments. In this vision, the goal is to develop timely and efficient care during the course of admission, but it's also, as I mentioned, based in quality and evidence-based care. So what kind of care is the patient receiving? And for this work, we based it on our standards of care within our hospital, as well as Health Quality Ontario's quality standards for schizophrenia, which are a set of statements that outline what a person with schizophrenia should be expected to receive in their care. We really base this in population health strategies to look at predictive analytical work and to also identify pain points and system opportunities to remove barriers, develop community partnerships, and work as a more integrated system. And eventually to expand this episode of care further to include housing and further reduce lengths of stay, and maybe we can avoid an admission entirely. What we did was map out the day standards for the patient, the ongoing care activities, and the exceptions to care. At the same time, we identified who completes these, the time to complete, and the frequency. We could develop an accompanying financial model. What this ended up looking like was a 61-day proof of concept where we mapped out all of the activities by day, and if they were a quality standard, a standard of care, or an exception to care, and we had an accompanying financial model. Now, what you'll see is there's a great deal of variation in the financial model depending on what care the patient received, and that is one of our next goals, is to look at how we can reduce variation. We did an analysis of the data to see how our current practice compared to this proof of concept model. We were able to pull from our system discrete data elements to map out the pathways, and also did qualitative audits for additional information that did not have discrete data. This helped to inform us on areas that we were meeting the targets or meeting the days and the pathways with, and the areas that we were not doing as well in, and it could provide us with quality improvement opportunities. We noticed significant variations in practice and time to gather collateral information, housing processes, and prescribing practices in measurement-based care. And this gives us the opportunity to further look at reducing variation, increasing standardization in care, promoting seamless transitions, integrated care, and quality of care. The next steps will be to develop predictive models for these services to identify what care a person needs and what we need to focus on during the course of their admission and processes to support. And then we can efficiently utilize inpatient clinicians to deliver inpatient components of the bundle and develop memorandums of understanding with partners in the community to help ensure seamless transitions and services for our patients. I know this was a quick presentation. Here is my contact information. Happy to chat and answer any questions that you may have about this work. Thank you.
Hello, my name is Marta Torres, researcher at Aquas and CyberS. The title of my presentation is New Challenges in the Evaluation and Adoption of Health Technologies, Prioritization of Innovation in the COVID-19 Pandemic. COVID-19 has highlighted the urgent need to invest and adopt innovative solutions. For this reason, an interinstitutional working group was established in Catalonia to accelerate the evaluation and adoption of non-pharmacological innovation during the pandemic. The group identified the need for a system or instrument to prioritize their evaluation. Pretech tool, a validated scale aimed to prioritize the assessment of existing health technologies, might be a good starting point to develop such an instrument. Therefore, our objective was to develop a specific tool for the prioritization of scientific assessment of health innovation targeting COVID-19 and giving the emergency to support the adoption of innovation in clinical practice. So the original Pretech tool was modified with permission of its authors by a working group specially constituted to develop the present tool. The tool consists in a 70-item questionnaire distributed in 5 different domains. In a first phase, Pretech items were adapted and refined according to our actual needs, and 7 innovative technologies targeting COVID-19 were scored by the working subgroup to obtain a preliminary version of the new scale, named Pretech Covid-19. The changes made on the original scale were agreed with all members of the working group. In a second phase, 5 additional evaluators scored 3 of the previous technologies. The current version of Pretech Covid-19 includes all the amendments suggested by all these additional evaluators. The variability between the evaluators' scores was then analyzed by ANOVA. As a result, Pretech Covid-19 contains 20 items in 5 domains. As in the original tool, each item is rated from 1 to 9. The final score corresponds to the sum of all items, being 20 the minimum score and 180 the maximum. Our major changes were the addition of an initial screening item and the addition of new items related to user experience, to scalability, follow-up of official recommendations, or level of implementation. Other items were adapted or refined. And we also reversed the rating scale of domains related to cost in order to prioritize those with a lower budget impact. The analysis of variances showed no major differences between evaluators in phase 1, but a higher variability between independent evaluators in phase 2. In conclusion, Pretech Covid-19 was developed by adapting the original Pretech tool and fine-tuned according to the opinions and experiences of all the evaluators. A higher variability was observed between the evaluators when the scoring was performed independently. Despite this fact, the tool showed phase validity and might represent a useful tool to prioritize the assessment of innovation, health technologies other than drugs, targeting COVID-19. However, our number of evaluators was small, with variability across their scorings. Therefore, it is needed to assess this variability with a greater number of evaluators and technologies. It is also needed to consider the application of specific weights to the domains as in the original tool. And once the tool is validated, we think it's important to disseminate it among potential users, especially considering that it can be customized according to new emerging health needs. I would like to thank my co-authors, Mireia Espallargas, Elisenda Rajab, David Magem, Dani Moreno, and Manu Jimenez, and also to all members of our working group, as well as you, for your attention. Thank you very much.
Hello, good morning. First of all, thanks to the organization for inviting us to present our experience about registry of patients and treatments of hospital medicines in Catalonia, a tool to improve quality and efficiency of hospital drugs use. My colleagues and I work at the Catalan Health Service. These are the main points of this presentation. The first one is the implementation and objectives. The registry is centralized and mandatory for all the public hospitals in Catalonia. It was designed in 2012 with three main objectives: monitoring the use of drugs, linking to a diagnosis, find out the adherence to the criteria set by the pharmacotherapeutic harmonization program, and assess health outcomes. The program appraisal new drugs and proposal the criteria for use and prioritization. This image is an overview of the program process. The main point is that the registry is key for the program's successful implementation. Characteristics and information. The registry has different information levels about patients and treatments. It includes baseline and follow-up variables. At this moment, it has a high number of treatments, patients, and information. The use of the data and evaluation of results is one of the most important points in order to support decision-making. The collected data provides information to be used for two different purposes: analysis of how drugs are being used, like monitoring of drug prescription, pharmacological tariffs, cost-sharing agreements, and budget models, and the analysis of the health outcomes, like evaluation of registered health outcomes, risk-sharing agreement as pay performance model, and effectiveness-based quality indicators. We shared information with hospitals and different commissions of CatSaluds. In addition, we publish it and make it available from Catalan CatSalut website. For all the evaluation of health outcomes, we have published several public outcomes reports. All the reports include characteristics of treatment patients, compliance with program recommendations, main treatment outcomes, summary of treatment costs, and benchmarking across hospital and compilation of real-world and clinical trial data. We shared these reports with the program, prescribing physicians, hospital pharmacists, and hospital managers in order to identify and share best practice across different territories and teams. And last but not least, the main challenges are to define and implement a quality plan, to improve the usability, and to connect with national registry to increase interoperability.
Muchas gracias for your attention, and this is my contact.
I'm Dr. Mary Grace Umali Santa Ana. I'm from the Makati Medical Center, Philippines, and I'll be presenting risk management and ensuring patient safety and high-quality healthcare services. Makati Medical Center is a 52-year-old hospital and has 600 bed capacity. Here, we live the culture of safety, quality, and compliance in order to provide high-quality care to our patients, its families, our staff members, and visitors. One of the vital programs in our hospital is the risk management program. It aims to protect the hospital assets, reputation, and quality of care against harm and the adverse effects of accidental loss. Our governance and hospital leadership provide supervision in order to achieve the following objectives: to identify, assess, prioritize potential risks, manage risk by selecting appropriate controls, and communicate the risk management activities hospital-wide. We follow this framework, which starts with risk identification assessment, risk prioritization, risk reporting, risk management, and evaluation. For the past years, we have been implementing this risk assessment activities. So we do failure modes and effects analysis for new high-risk processes. We do pre-construction risk assessment and infection control risk assessment for construction and renovation. We use the HIRAC, or the Hazard Identification, Risk Assessment and Control for occupational safety and health. We do department level and hospital common areas environmental rounds for facility safety and management. We do HVA, or use the Hazard Vulnerability Assessment for disaster preparedness. For safety events, we conduct root cause analysis, and we also do risk assessment for our infection prevention control program. This year, we focus on enterprise risk management for strategic planning. We also conducted the facility-wide risk assessment, which covers facility security, safety, hazardous materials and waste, fire safety, medical equipment, utility systems, and construction renovations. We also did the data privacy, impact assessment, data security, and to ensure that performance of essential functions during events of disruption, we have business continuity. The risk management program information through infographics and memoranda are cascaded through the virtual meetings, email advisory, and dissemination to the Viber groups. To share with you the highlights of ERM, which we conducted last 2020, our Quality Management Division, Clinical Safety and Risk Management, assisted the Senior Quality Management Council in examining the 2019-2020 events. Risk which impacted safety of patients, staff members, visitors, and resulted to damage or loss to the organization were identified through the following sources or reports. Data are entered in the inventory form. So initially, we identified 48 risks, and then it was categorized into the following domains, and were shortlisted to 14. For priorities, we focus on human capital, specifically on hiring and retention, financial, and facility management-related risk. And the strategies were incorporated in the 3-year strategic plan. For the failure modes and effects analysis that we have conducted from 2019 to 2020, the quality, safety, and compliance champions of the identified high-risk process owners organized the risk assessment team. They analyzed the current and compared it to the to-be processes, identified the risk and the risk management strategies. They identified the failure modes, possible causes, and the failure effects. And all data are entered in the following forms. So these are some of the new high-risk processes wherein we utilize the failure modes and effects analysis. So I'd like to end this presentation by stating that The continuing implementation of our risk management program strengthens our efforts to have a systematic and proactive approach to recognize and control hazards. This reinforces our goal to guarantee patient safety even in unprecedented conditions. So thank you for listening.
Our next presentation is entitled Achieving High-Value Surgical Care by Optimizing Operating Room Cost Transparency and Accountability. Porter's definition of value in healthcare is such that value is optimized when one optimizes quality and service to our patients, while also optimizing cost. To increase value, one must drive quality and contain costs. The problem with healthcare delivery in the United States is we're on the downward slope of the value curve. For each incremental increase in cost or expenditure, we're seeing a decrease in the overall value of care we deliver. To optimize value, we have to optimize this balance and optimize the value equation. To help in understanding costs, the University of Utah developed the Value-Driven Outcomes tool, which is a modular extensible framework upon which activity-based costing is used to allow us to study all variable costs and variable overhead involved in delivering a single point of care to a patient. We modified the Value-Driven Outcomes tool to create the Operating Room Cost Accountability Project, or ORCA. ORCA allows us to assess accurate operating room cost data in real time, provides awareness to surgeons and leadership of supply cost decision impacts by case, allows the surgeon the ability to compare OR costs with oneself and with peers over time, and to take action in allowing the surgeon to make ongoing changes in their usage choices to reduce OR supply costs and improve value. This is an example of the output of the ORCA tool, here showing my cases for a period of time about a few years ago. Cases are presented as, data is presented, as a case count, the average cost of a preference card, the supplies opened in the operating room, the average cost of the supplies used, and a coefficient of variation to allow us to look where variability is a possible driver of inefficiency and cost. Looking at an individual operation, here's a report of 7 surgeons performing the same operation. In the upper part, you'll see supply costs, and the bottom part, you'll see OR time. The variable costs and the variable overhead associated with performing an operation, both variable inputs drive cost. Highlighted here are differences in supply choices that impact cost. Here, differences in the mesh chosen, 6-fold difference between low and high cost mesh to achieve the same outcome. Also highlighted here are costs associated with variation technique, whether one uses a balloon dissector or not. Balloon dissector is not necessary and is just another cost element. And there's a 3-fold difference in operating room time, which is a variable overhead associated with performing an operation. And at individual surgeon level, we can also produce all of the data of a single operation for a surgeon and click on an individual account, linking back then to the electronic record to understand why there was such variability from patient to patient. ORCA allows us to make individual surgeon decisions to derive value, but it's scalable and such that it allows us then to identify stakeholders that perform a single operation. Again, to look at standardization of supply costs and to elicit stakeholder input when we go to do things, for example, as contracting for additional supplies. What we have appreciated in implementing ORCA is that it informs cost and quality implications of surgical treatment choices. It informs individual surgeon and multi-stakeholder conversations about value. It inspires action with meaningful uses. And most importantly to us, it enhances our health system organizational culture aligned around delivering high-value surgical care. Thank you very much.
Thank you for inviting me to present on the Sláinte Care Integrated Community Chest Pain Clinic, impact of transforming chest pain assessment from the hospital to the community. My name is Shirley Ingram and I am an advanced nurse practitioner in cardiology at Tala University Hospital, Dublin, Ireland. Chest pain is a significant burden to both emergency departments and primary care. In our hospital, which is a large teaching hospital in southwest Dublin, there are annually over 50,000 presentations to the emergency department, of which 9% are usually with chest pain. And this has grown year on year as the numbers have increased. And also during the pandemic, chest pain was still a big presentation to ED. Chest pain is also a significant factor in primary care assessment. And GPs lack access to direct assessment and often are forced to send their patients to the emergency department. As such, 31% are often referred by the GP and 70% of these are low risk and often discharged home. This can involve a long wait time for the patient and exacerbate overcrowded emergency departments. Sláinte in Ireland is usually a drinking toast. It means cheers or good health. However, in the Irish context, Sláinte Care is now a 10-year programme to transform the Irish health and social care services, finding, supporting and scaling innovative, integrated ways of shifting care to the community, helping to reduce and prevent hospital visits and providing hospital avoidance measures. And this is where the Integrated Community Chest Pain Clinic sits. And this is a photo of the working group of the team. I'm an advanced nurse practitioner. An advanced nursing practice is defined as a career pathway for registered nurses to practice at a higher level of capability as independent, autonomous and expert practitioners. So the general practitioner sees the patient with chest pain. They can refer directly to me in my community clinic. I'm assisted by a 0.5 admin post who prioritises the referrals. I carry out a face-to-face visit with the appointment, and this carried out throughout all the lockdowns during COVID-19. I carry out an advanced physical assessment and formulate a differential diagnosis. And this is a typical case of a female, low-risk female who avoided ED by coming to the clinic. Cardiology diagnostics, if required, are provided by a 0.5 senior physiologist, and this is where the integrated piece kicks in. The integrated care is provided in Tala Hospital Diagnostic Department. Once the diagnostic has been performed, I ring the patient with the result and complete the episode of care. I can discharge autonomously back to the GP, or I can manage the patient in collaboration with the cardiologist if the patient is complex or needs further evaluation. And a third of patients did not require any initial diagnostics at all. Health promotion is vital, making every contact count. At 1 year, we have received 460 GP referrals, which is 15% above our targeted objective. There was over 700 appointments. 67% of all the patients were discharged after 2 visits and managed autonomously by myself. And so far, the service has proven safe. 4 patients required transfer to the hospital. And again, this was another element of safe integration as I liaised with the hospital chest pain nurses or ED. Patient feedback has been very positive, ranging from being a lifesaver to giving peace of mind. 75% of our local GP practices have engaged with the AMP clinic, and GP practice has been very good. And now most GPs are saying it is an essential service. Whilst the majority of pain is diagnosed as non-anginal, as is correct for this low risk cohort, 12% were diagnosed and treated for coronary heart disease. This impacts on the avoidance of collateral damage caused by the pandemic on those with cardiovascular disease who were afraid to present to busy emergency departments and hospitals. The third outcome achieved has been the reduction in non-acute chest pain presentations to the emergency department by the general practitioner, from ED to my community. And in conclusion, this clinic has innovated in shifting care to the community. It has been safe and builds on 10 years of AMP practice. Thank you very much.
Good morning, everyone. It's an absolute pleasure to be with you today and to present this initiative that we're implementing at KIDA Home Care. Thank you so much for the opportunity. Basically, what I would love to talk to you today is about, first of all, the context, right? We all know that there is a lot of an aging population. At the same time, we have the cost of healthcare and social care increasing at 2-3x the annual rate of growth compared to the GDP. So basically, we cannot pay for it. And thirdly, the COVID-19 has changed and accelerated all these factors. And so when it comes to home care, when it comes to KIDA, we thought, well, we might as well do something about it and try to keep people longer at home with good quality of life. And so what we did is to start a project, the KIDA 3 years ago. Today, we are employing over 100 people, and we are attending over 1,200 patients every day. And so we decided to put 3 main pillars. Number one is transforming the model of care, which I will talk a little bit about today. 2 is evaluate and assess the impact of this new model of care. And finally, ask the patients what's their perception on it and how their life has improved. In this regard, we've mainly put 4 pillars when it comes to our model of care. And we've been working on it the last 12 months. And I want to highlight a couple of elements. Number one is that we really bet on a multidisciplinary team. We have both social workers, occupational therapists, psychologists, nurses, physiotherapists, all of them working and coming together in this team. Number 2 is we really put a lot of effort when it comes to our caregivers, right? We believe that they should get the right training, we believe they should get the right community, and we believe they should have the right labor conditions, right? And what we do is to put a lot of focus on selecting and recruiting the best caregivers. Number 3 is around technology, right? We're investing over 2.5 million in the last 12 months on technology, right? And what we're trying to do is 2 main things. The usual thing, which is technology for efficiency, technology for quality, but also technology to really use data to prevent and really know what's going on in that house. And finally, the way we work at KIDA is, I think, our main competitive advantage. And really, we put a lot of effort in being diligent, in communicating well, in having a multidisciplinary team, in listening to all the opinions and working all together as one team. What these 12 months of transformation has led is to 5, I would say, quite outstanding results. We are not only attending way more people, but also these people are living 120% more time at home. We've also managed to reduce by almost 90% churn. Churn is the rotation of the service and the rotation of the caregiver, as well as increase, hence, the duration of the caregiver at home, creating good, empowered communities of caregivers and patients that at the end live well at home, where we have 98% of our patients saying that they feel in good hands. And so this is all for today. Thank you so much. And we would be really keen to share more about this with you at KIDA, as well as in our social network. Thank you so much.
I want to show our work about patients' reported outcomes. Do they have influence in the right choice of venous access? Patient-centered care is the practice of empowering patients and represents a change from the traditional disease-centered approach. The science of implementation provides conceptual frameworks for understanding how organizations can implement evidence-based practices with discrete but applicable clinical practices to assess the implementation of a broader patient-centered care transformation at the system level. PROMS and PREMS focus on improving the quality of care services and patient autonomy, improve communication between patients and healthcare professionals, increasing patient satisfaction. One of the practices mostly carried out in hospital settings is the implementation of a vascular access device. The quality and care indicators we studied were successful cannulation, choice of the right device, correct management and care allowing administration of treatment, avoid repeated attempts, reduce the number of complications and waiting time in the implementation of vascular access device, and vessel health preservation. Our aims were two. The first, to understand adult hospitalized patients' experience susceptible of vascular access device cannulations, PREMs, and to establish aspects related to the insertions, care, and appearance of complications relevant to them and for healthcare professionals, PROMs. The second aims were to show the need to create vascular access teams with a multidisciplinary approach, showing that teams already constitutes reduced complications, shorten hospital stay, and improve quality perceived care. The methodology we used was in order to evaluate patient quality perception related to vascular access. A survey was developed based on already validated questionnaires. The questions were elaborated by vascular access nurses belonging to 4 hospitals in Spain in different cities: Madrid, Gerona, Santander, and Zaragoza. For PRIMS analysis, staff include adult patients who have a vascular access device during hospital stay and their experience. The variables analyzed as PROMs were basically vessel preservation, end of the treatment, and cost effectiveness in terms of complications, among others. In this slide and the next one, we can show our results. We study 400 patients at all, 70% women and 30% men, with an average age between 75 and 75 years. We use different types of catheter: PIP, mini-midline, midline, PIC, and PIC port. And we study some aspects like pain during cannulation or the comfortability of vascular access. Also, catheter drawbacks, dislodgement, shower, cosmetic results, number of vascular access device during hospital stay, grade of satisfaction with the vascular access device, and grade of importance of cannulation vascular access device. Also, the importance of only one vascular access during hospitalization according to treatment, vessel health, and hospital stay, and cannulate by vascular access expert, 10%. The results about PROMs are being evaluated in this moment in terms of complications and costs such as phlebitis, thrombosis, dislodgements, etc. Our conclusions are that all interventions surrounding vascular access insertion can be a painful and stressful experience for patients. It is well known the importance of providing appropriately education and training to ensure best practice and high quality care. Specific strategies to improve the patient's experience of insertion and care include pain relief for venous access insertion as standard practice, or decision-making tools which include patient preference in site selection and vascular access daily assessment tools which encourage patient input. Definitely, future practice and research should focus on outcomes and strategies important to patients and on ways to improve their participation and engagement in their care. Listening to them and taking actions will be a good first step. Thank you very much.